For our people with cervicogenic headaches, we know that there could be occiput C1, they could be C1, C2, they could be C2, C3. We know that scalenes have different attachments like IOCs kind of going from C2 up to C1. Rect cap posterior major is kind of moving from C2 straight up into the occiput, and then SOC is kind of going from that transverse process up into the occiput on the side. And so we have that entire suboccipital triangle that could be affecting joint motion, occiput, C1, C2, and C3. So we want to be able to do the best treatment to get the best outcomes. And in order to do that, we really want to try and find which joint is the most hot, which one is the most painful, which one is the real comp sign. In order to do that, we really have to differentiate. So we're going to start with occiput on C1. Remember, we talked about that 30-degree toe in of the occipital condyles. So when we do our assessment of C1 moving on a stable occiput, your force is going to be directed towards the ipsilateral eye. So it's not straight down. So I'm going to get right on C2. There's the occiput, that divot in between right there. Remember, is going to be that arch of C1. I'm going to go about 3 finger breadths over, and that's going to say where I should start to try and palpate that occiput C1 joint. So I have found it right here. Most patients, as soon as you push down on it, they'll be like, yeah, that's it. They'll be able to feel a difference between that and you pushing into empty space. You should also be able to feel that because it's a sudden stiffness right underneath of your thumbs. So you can kind of see there's her eye right there. So that's going to be the direction, not straight down, but up towards the ipsilateral eye. So I'm going to get over top a little bit, and my force is then straight down. So there's R1, back off, a little further in, back off. R2 is right there, back off. You should appreciate some pretty decent motion of occiput on C1. Okay, so towards the ipsilateral eye for occiput on C1. For C2 on C3, you're going to find that spinous process of C2. This one will be a more pure unilateral posterior to anterior. So that's C2 on C3. To assess C1 on C2, we're going to pick up some of that slack from the occiput on C1. So I'm going to rotate the head 30 degrees while keeping my same force through here. I am then going to push down, so I've essentially locked down C1 on C2. So now when I'm pushing down on this, I'm biasing, moving a C2 on a more stable C1. Okay, so to go through that, occiput C1 is towards the ipsilateral eye. C2, C3 then is the standard unilateral posterior to anterior that we've been assessing. You'll then want to maintain your grip, turn the patient's head 30 degrees, and then do another unilateral posterior to anterior, and that will bias C2 on C1. The entire time, you're trying to find which one reproduces their comparable sign the most with the least amount of force. Okay?